I'm Paul Iaizzo. I'm one of the co-organizers, professor here at the University of Minnesota. And over the years, I've had the extreme privilege to organize the cardiac keynote session. And we get to invite world experts to give keynote talks. We have Dr. Berul and Dr. Iaizzo from either sides of the Atlantic Ocean. And they're both leaders in the field of electrophysiology. And we switched the order. So Dr. Berul's going to go first because we have him kind of giving a focus on pediatrics. So we're going to go through the aging process a little bit. And so with that, Dr. Berul, please. We're looking forward to hear what you say, and then we'll have time for questions and answers from both of them.
Okay, well, thank you, Paul. Thanks for the invitation. This is, if you count the virtual year, my 4th time attending the DMD conference. And so I'm grateful to be invited back. So we're going to talk about pacemakers and defibrillators, focusing on pediatrics. Here's my disclosures. And we all know children aren't just small adults. And so you have to think about when you're implanting a pacemaker or defibrillator in an infant, that they're going to grow many times, and you have to plan when you're putting in a device in a small child for what's going to happen to that device and when they become big adults, hopefully not that big. And so that's really the challenge and the problem of device implantation in children. It includes their size as well as their anatomy, the vascular access and roots. They've got obviously smaller veins. Many of them have congenital heart disease, so there may not be direct access to the heart, as well as cosmesis, putting in a big device in a small child. And as we know, most devices aren't designed for small children. I love this picture of this tiny premature infant who's about the size of that temporary pacemaker box next to him, and all of the medical technology associated with that child. So the standard way of putting in a pacemaker is either transvenous or epicardial. And you see what we try to do in a transvenous system is put that extra slack in the lead, hoping that the slack will come out as the child grows and not have to replace it because the child has outgrown the lead. And then the standard epicardial approach, just putting sew-on leads is typically what's being used on the outside of the heart, and then the generator goes in the belly. That's been the standard approach for decades. But the problem with transvenous leads in small children is really the vascular access. And it's very hard to predict. We have looked at it in age, size, and lead factors alone aren't very good predictors of venous obstruction in children with transvenous leads. You can see this major obstruction here. For those of you who don't look at a lot of venograms, you can see this is a subclavian vein, and then here's the pacing lead that goes through, and everything's blocked from there, and so there's collateral. So the blood eventually gets back to the heart, but it'd be a challenge to put a wire or a lead through that squiggly spider nest of veins. Now, that's the one movie that didn't play, so Dr. Iaizzo says you can look it up on the Visible Heart and have it play, but leads are under constant strain, and this beautiful picture from the Visible Heart shows a defibrillator lead in a beating heart, and you can see the lead flexing. If this is the only movie that didn't play up here, played at home. And so in comparison to transvenous systems, epicardial open chest pacemakers or defibrillators are also not ideal for children. They often result in a big scar, either midline sternotomy or a thoracotomy scar, and a still relatively big generator in her belly. These pictures are used with permission of the parents. So this little ballerina's got a pretty big bulge in her belly from just a regular old pacemaker sitting there that was placed when she was an infant. And sometimes with congenital heart disease, you just can't get there from here. And this is a cardiac catheterization. You see a lot of hardware here. You see epicardial leads. There's an epicardial screw-on lead. There's a sew-on lead. This is abandoned. Here's an old abdominal pocket with no pacemaker attached to it. And here we're doing a venogram to show this is dextrocardia transposition, and there's a baffle here. And you can see that narrowing there where the baffle narrows down. And so it'd still be a challenge to get a lead through that narrowed channel. And sometimes the surgeon makes it almost impossible to get a lead in the heart if you have congenital heart disease. This is a patient who has a Confernce procedure because he or she was born with one ventricle, and this is the way of survival by surgery. And what they do is they place a conduit going from the inferior and superior vena cava around the heart, an extracardiac conduit. And so if you try to put a transvenous lead coming down from the superior vena cava, you're going to end up in a plastic tube, which obviously would be a challenge to pace from. There are ways that you can technically get through there, but it adds an additional challenge. Now, pacemakers and defibrillators have come a long way. This is the first year I started, 1994, and I got this nice plaque from about a 10-year-old that I implanted with a defibrillator, and you can see all the junk in this kit. There's a lot of abandoned space junk that was put in this baby. Lots of epicardial leads coiled around in the heart and in the pleural space, an abdominal pacemaker, and an abdominal huge generator. And when this child got her, this is not this patient, but when this child got her defibrillator, she was the smallest patient or the youngest patient to receive this defibrillator. She's now almost 40 years old, I think if I do the math right. Her birthday, 1984. She's almost 40 years old. She's outlived the company. This company's not even in business anymore. And she's still in business thanks to a pacemaker and defibrillator. And recently there's been expert consensus statements figuring out and making recommendations on the indications and management of implantable devices, specifically for pediatric patients. This is sort of long overdue. We've been putting devices in children since devices came about. In fact, some of the first pacemakers were put in here in Minnesota in a child. And so there's been major advances since then with recommendations, class indications as to who should and who should not get a pacemaker. I'm not going to go into all the guidelines, but just to show that there are guidelines. So what's new that's good for children? In terms of generators, devices have gotten a bit smaller over the past 3 decades. Miniaturization of these devices is feasible, but there's a very small market for putting devices in children, so there's not much of an incentive for manufacturers to make a pediatric-specific defibrillator. Children require lower defibrillation energy because they're smaller, and so you could make a smaller device that packs less joules into the device. I'm hoping I can excite some of the engineers in the room to figure this out. Now, battery and capacity technology is improving. It's not this old capacitors and batteries, and devices have gotten smaller, so we should be able to develop a pediatric-specific defibrillator. Now, I don't know if anybody here watches that show with Jane Lynch called The Weakest Link. I always think of that show with this picture because leads are really the weakest link in the system. And especially in children, leads break. And we think about most pacemakers and defibrillators go in people over 60, right? I'm now just over 60, so I'm in that group now. So I used to say they were old. Now they're not so old. But so most of these devices are going in people over 60. Many of the devices are going in people over 80. And so if the lead lasts 20 years, that's pretty good. You may only need 1, maybe 2 leads in your lifetime. But if you're putting a pacing lead in a 3-year-old, you're hoping to get 90 years of life out of that lead. And it's not going to happen. Leads don't last 90 years. We're happy if they last 20 years, and then you need to get a new lead. And the reason we wanted thinner leads, thinking that would be better. And so we begged the manufacturers, all of the pediatric implanters, said, please make us thinner leads because maybe we'll get less venous obstruction and that would be better for children. And several manufacturers said, oh, that's a good idea. But thinner isn't always better. There's been several leads that have been out there, defibrillator leads. Defibrillation leads are much more complicated than pacing leads, and they have multiple conductors and coils in there. And so there's more things that can break in a complicated lead. And here's two examples of problems with thin leads without naming names. Well, I guess they are named there. So this is a thin lead that had problems with the insulation between the conductors, causing electrical noise. And sometimes for those who don't read these channels, this is marking fibrillation sense. And so the device thinks that the patient is in ventricular fibrillation and will try to deliver a shock. And shocks are great if you need a life-saving shock. Shocks aren't so great if you're just sitting around doing nothing. And people don't like getting shocked when they're not supposed to. And it hurts, and it can lead to other arrhythmias. And in this thinner lead, there really wasn't enough support around the conductors, and the conductor cables extruded out through the insulation. So both of these are sort of different problems leading to lead failure, and they both had a survival rate of about 70% when you get out here to 5 years or so, 5 or 6 years, about a 30% lead failure, and they were comparable when they were compared. And so we performed, this was for a big study that we did back about 15 years ago, a multi-institutional pediatric study, prospective randomized study comparing thin leads to standard leads before those leads were recalled. And one of the issues is those thin lead failures impacted children more than they impacted adults, because we as pediatric electrophysiologists thought thin leads are great. They're better for smaller children. And so here's less than 8 years old implanted. 75 or 80% of them received thin single coil leads, of which 35% of them failed. Again, as you get younger, you have a higher incidence of using the lead. They were chosen by the implanter, and a higher failure rate of those thin leads. So disproportionate effect on children. And when you compare the thin leads to non-thin leads, you can see in this Kaplan-Meier survival curve, the failure rate was significantly higher in the thin leads compared to the non-thin leads. So what do we do with these old leads? It becomes an issue with people who have leads in for decades. You can abandon them. If you're 80 years old and your lead fails in 10, 15 years when you're 95, you could probably abandon it and just leave it in place. We used to do the manual traction extraction method. I call it the big jerk method, and you can interpret that both ways of the word jerk. But it's, you're basically pulling on the leads with weights. Nobody really does this anymore, but this is how it used to be done before there was better technology, thanks to engineers, right? So the patient would be put in bed, traction with weights would be applied to the lead until they eventually pulled out. And it's pretty dramatic. Now, mainly we use other technology, either laser, radio frequency, to cut out the scar and get around the scar, or I call this the apple coring tools, these mechanical tools to go around and cut around the scar that forms a pretty strong fibrous scar around the leads. And it's even tougher in children. Here in this group of expert extractors, you really have to pull hard to get the lead out, and sometimes you get a little piece of the heart along with the lead. And so there's risk in abandoning the lead, there's risk in extracting the lead, and they have to balance that together. And so I think in the future, the goal is going to be to not have endovascular leads in place, because they're really the problem in taking them out. Taking out generators from subcutaneous or even submuscular generators is not that big of a deal, but taking out transvenous leads that have been in for a while carries risk, including a risk of death. And so many people and many manufacturers think the future is non-transvenous systems. So we thought of this over 20 years ago. There were 3 different investigators in 3 different countries that published within a month of each other in 2001 of a concept of a subcutaneous ICD system at that point. We used the subcutaneous array here with one of the other companies in Minnesota. I can't say one of the other companies. I'm not here at a company-specific presentation. So this is one with a 3-finger array. This is one with a single finger coil with a generator in the right side of the abdomen. So if you imagine an external defibrillator with the paddles on both sides of the heart, that's sort of what it's like, except it's under the skin. So here's an array that's just under the skin on the left side of the chest. The energy would go, you could imagine that going through the heart. Same here, the energy goes from the coil to the can with the heart in between it. It still required epicardial pacing leads in both situations. And it still amazes me, this is 2001, it still amazes me. This is the US, Germany, and Denmark, 3 different groups, almost the exact same idea, and none of us talked to each other, and they were published within a month of each other in 3 different journals as case reports. Now there's been hundreds of children that have been successfully reported, including some papers with multi-center longer-term results. We weren't savvy enough to get the IP, and now, as you know, there is a subcutaneous ICD that we're going to talk about. The other route of putting leads in that aren't endocardial is pericardial. So the pericardial lead goes in, again, surgically placed and goes behind the heart. You avoid the problem with patches, which almost nobody uses anymore. Here, again, you still require the epicardial pacing and sensing leads to detect, to pace and be able to detect the arrhythmia. Here's a pericardial lead, and this particular child also happened to have a subcutaneous coil. And so what that looks like in a video view, here's an epicardial pacing lead being screwed on to the heart, and there's the pericardial coil being placed surgically behind the heart. And so you can see the surgeon has a pretty good view there, and you can see him moving the lead. I don't like them putting the clamp on the lead as they turn it, but rotating the pacing lead onto the heart for pacing and sensing, and the pericardial lead behind the heart for defibrillation. And so now there's really 4 routes for defibrillator placement in children. The 2 standard routes, transvenous, again with that coil, an extra loop of lead, epicardial patches, which, as I said, nobody uses anymore, the subcutaneous array or coil, and pericardial. So those are sort of the 4 routes of ICD implantation in children. But these non-standard approaches may not be as durable as the standard ICD implants that are matched by diagnosis, age, and implant date. And so this is system survival of non-transvenous systems. So some of those novel systems, not the commercially available ones, but some of those novel systems, either pericardial coils or subcutaneous arrays. And what we see here is by 3 years, half of these children needed something done, needed the system replaced, either because of the generator or because of the lead, compared to only about 15% with a standard transvenous system. But so the hazard ratio is about 2.9 or 3 times the risk of needing something done within 3 years. It's important to recognize that most of these children who received the non-transvenous system weren't eligible to get a transvenous system. So they didn't really have any other options. They were either too small or they had complex enough congenital heart disease that they would be precluded from getting a transvenous system. So this was really their only option. But we have to recognize that those novel approaches may not be as durable as a standard lead. So then the subcutaneous ICD came out, a non-transvenous defibrillator system. Everybody's seen this picture, or many of you have, at least that are clinicians, with a shocking coil parasternal here just under the skin, and a defibrillator there with no wires in or on the heart. And so that became commercially available. And here's the report of the first 7 children who received that system. This is, they ranged from 10 to 17 years of age and weighed from 32 to over 100 kilograms. And here's the picture of the smallest patient, 10-year-old with the coil there, the can there, pretty big can compared to the size of the kid. And you can see cosmetically, that's a pretty big can for a skinny little 10-year-old, but works well. Here's a time he was playing video games with his brother. They were sort of fighting about the game. He said he felt dizzy, lost hearing, and then passed out. His brother was the witness. And here, 25 seconds later, he gets shocked after being in ventricular fibrillation and shocked into normal rhythm. So they work. 25 seconds is a long time, but if you're just sitting there playing video games with your brother, it's okay. If you're driving or up on a ladder, that may be too long of a time. They have gotten better. That was version 1. Version 2 is a bit smaller and better, longer lasting, less thick, less volume, less weight, higher longevity. But it's still pretty big. This is one that I put in the past year in a teenager. We usually put them submuscular because of what you saw in that cosmetic picture of the device bulging out. Put them in submuscular. It's a little bit of a bigger surgery, and both when you put it in and when you go to change it. But I think it's got a little bit better padding and better for active teenagers. There have been reports in the literature about the subcutaneous implantable, the ICD in children and congenital heart patients. One from France showing they have to sort of bend or bow the coil to fit in a smaller chest so that the coil stays by the heart. And in this patient with dextrocardia, kind of cute picture, it's not just that they reverse the x-ray, patient's heart's on the right side, so they put the can on the right side so that the heart is between the can and the defibrillation coil. There have been reported concerns from this group and others about a higher risk of infection in young patients. That's true with any kind of system. We've seen that in standard transvenous systems too. The infection rate is higher in children than they are in adults, and you can imagine lots of reasons. Maybe they play with their incisions, or maybe they're just more active. Maybe they're just more prone to getting infections. There's a lot of hypotheses, but many reports about ICDs, both subcutaneous and standard transvenous ICDs, the infection rate's higher in children, and so that is a concern, especially with those bigger devices. Been a couple of problems with the ICD that have been more common in children and in adults with congenital heart disease. Here, the patient has a supraventricular tachycardia, or SVT, usually not a life-threatening condition, and they still got shocked. It did convert the SVT, so it treated it, but there's less painful ways to treat SVT than a shock. And here, this is a big issue with the subcutaneous ICD is T-wave oversensing, where the device is double counting. It's counting both the QRS and the T-wave, and that seems to be more problematic for the subcutaneous ICD than for transvenous ICDs, and particularly in younger patients and certain diseases where the T-waves are bigger and hard to differentiate from the QRS. So sometimes you have to be creative and do things that aren't what the manufacturer recommends. They certainly don't recommend doing this. So sometimes we have to just do novel things. Here's something that got some excitement. Maybe some of you in the audience know more about this than I do. This is the so-called subcutaneous string defibrillator from New Pace in Israel. This abstract was presented 6 years ago at the Heart Rhythm meeting. The implantable subcutaneous string defibrillator, a totally integrated device with no leads in or on the heart, a wireless rechargeable device with no generator or lead. This is basically the whole system. You see it just goes in next to it and loops around the heart and can be implanted as an outpatient in 20 minutes. I haven't seen anything since then. I've looked on PubMed, I've looked through Google, and I've tried to talk to the company. They're still in business, I see, but I haven't seen anything in the past 6 years. So maybe. Here's another novel approach that people have reported using a coil, subcutaneous coil, put in the substernal space. And this was published as a way of, similar to the subcutaneous ICD. This is a substernal coil, and this sort of preceded idea of what has come out now as the substernal extravascular ICD. Again, that same concept of staying out of the endovascular system, staying out of the veins. And here you can see the coil just under the sternum and the defibrillator on the side, similar to the subcutaneous ICD, except it's substernal here. This is the report of the development of it. And what they report in this report is that it requires less energy, more similar to a transvenous ICD in terms of defibrillation energy was significantly less with a substernal ICD than the subcutaneous ICD. I'm actually not really sure why, because the vector looks about the same. Maybe this is a little bit more rightward because it's under the sternum rather than next to the sternum. But that's a pretty big difference in the defibrillation threshold, which may allow for a smaller device because you don't need to charge up to 80 joules if the DFT energy average is only 14 joules. And so this was just recently reported in the New England Journal, the safety and efficacy trial, and they reported, where is this? They reported a pre-market non-randomized trial with 356 patients enrolled. Of those, 316 of those patients received, had an implant attempted, so 50 didn't even get an attempt. They did a defibrillation test or threshold test in 302 of them, of which most of them worked. And by 6 months, about 25 major complications, or 8%. 17 were not implanted and 8 others removed within the first year. And 118 inappropriate shocks in 29 patients, or 9%. It seems like a lot. It's not that much worse than a standard transvenous ICD in terms of complications, and inappropriate shock rate of 9% is pretty typical. But it's, this is a first pre-market trial, and it's an exciting, novel, new approach. So I think it's gonna get there. Now we're gonna talk about small children, focusing on that. And epicardial access, putting devices to small children, is a risky business. And so I'm going to talk about our work and some of the work we've done with trying to do epicardial pacing defibrillator leads and the long journey towards percutaneous pericardial pacing. Our first publication in 2013, and I recall one of my engineers presented here at this conference at one of the 5-minute pitches this year on this concept with this. So we've come a long way in the past 10 years since he presented that, and this is a port that we've developed that started out as that prototype at the top, and now here's sort of the final plan that's being made to put a camera through one port and a pacing lead or whatever you want through the other port, and be able to watch what you're doing. And so when you put it through the skin in that retracted state, then you push it down and it expands. And I'll just show you a couple of cute little pictures of how this works. This was the prototype of it, and you can see the 2 holes. You push it down and just in the subxiphoid area and pinch it into place. I have the picture of the pig there to remind me that this has only been done in animals so far. We have not done this in humans yet. And then from the inside, this is what it would look like. That's just a chicken breast, but that's how it pops out under the subxiphoid area to lock the port into place. And that's sort of the investigational workflow, where we put the camera through and you can see what you're doing when you're putting a lead into the heart. Here's Dr. Clark, I'm not sure if you're in the room here, when he was a fellow, doing it in a tiny piglet and using the camera and getting pericardial access through the port. And you can see you can put pacing leads through with very good visualization, and those leads can pace. This is on the left atrial appendage, so you get left atrial pacing. We can get ventricular pacing with this system, and we compared this head-to-head with open chest epicardial or pericardial ICD placement in a piglet, using having our surgeons place them on the heart and then comparing them over time with using the port versus open. And just to show you what that looks like, this is a 40-second video, not as long as the first keynote speaker. And there's no singing like in the first one. So the needle goes in through the pericardial space, and then pericardiocentesis wire goes through. Again, you can see what you're hitting with that needle, and you can avoid critical structures like coronary arteries and veins. The sheath goes in over the wire like a Seldinger technique, and then you can see there's the dilator, and then the sheath pops through the pericardium, and then an ICD lead or whatever you want can be placed through that sheath, fixated onto the heart, and you can see the coil there at the tip of the sheath, we turn it to fixate it to the heart and then pull out the pericardial sheath, and you see just a tiny little defect in the pericardial space there. So that's really the whole procedure as seen from the inside. And we've put these in piglets and left them in for months at a time. You can see them fixate into place. You can see the fibrous capsule that forms around, just like anything else. The body forms encapsulation around any foreign body. There's an anchor sleeve here, and you see the fibrous tissue around the epicardium. So the next thing we did with the help of some of our colleagues here from Medtronic was to develop this prototype miniaturized pacemaker, utilizing what looks like very similar look to a leadless pacemaker, to a Micra, with a cap on the end and what we called a leadlet. And so this is the generator here. There's an anchor sleeve and the leadlet with an electrically active tip there, which has a flared helix at the end to attach it. And the pacing catheter is active with a pacing anode right there. So that's basically the whole pacing system that we put in through the port, and that's the whole thing, so you don't have to connect it to a big generator. So this might be ideal for really tiny neonates. And that's actually our goal, is to use this for the smallest of patients who are even too small to get a standard epicardial pacemaker in place, and doing it percutaneous. And so this is basically what the lead looks like. You see that flared helix attached to the pericardium, and the pacing anode is there. But until we get to truly percutaneous, this just got published a couple of weeks ago, where we put in these tiny pacemakers, and thanks to people in the audience that are here that helped bring this to fruition. So 5 tiny babies in 4 centers around the country were born with complete heart block and were deemed too small to get a standard epicardial pacemaker. So here's a standard pacemaker here. This is basically what's called a pediatric implantable pulse generator, which basically has a Micra in a casing. So here's the Micra, the casing with an IS-1 port to plug a standard pacing lead in. So these children still need open chest surgery to put the lead on, just a standard epicardial sew-on pacing lead. So they still need that, but they're getting a tiny pacemaker. So here's what this pacemaker looks like overlaying what a standard pacemaker would be in the belly. And so particularly for the 1 kilogram baby and some of the 2 kilogram babies, they're pretty tiny. You try to put one of these in them, and it doesn't fit. You can imagine, I've eaten lobsters that big. So they're tiny patients. So 5 patients in 4 centers all had acute recovery and did well. And so that's the first report of that. This is what it looks like. So again, you're getting a standard epicardial pacing lead, so they still need open chest surgery to get that put on, either a small xiphoid or sternotomy incision or thoracotomy. But this generator is much, much smaller than a standard generator. So our next step to finish up is a true percutaneous, inline delivered delivery system. This is what we've been working on. Everything's in line through a needle. This at the bottom is what the camera looks like. It's basically an illuminated scope with a needle attachment. And here's what it looks like. You're putting a needle in the subxiphoid region. Here's the video of that needle entering the thoracic space. And then you see the heart. This is the bevel of the needle here. That's the left lung. You can see the heart beating. The needle goes up to the heart and to the pericardium and tents the pericardium carefully. It's just a small needle, but it looks huge on this video. And then when you can image the heart with the scope, and then as you tent and make a small hole in the pericardium, you can then get into the pericardial space and then light up the pericardial space and be able to see in there. That's the left atrial appendage flapping at you right there. And so once you're in the pericardial space, you can do what you want in there. And my 4 o'clock talk is going to be talking about pericardial access and various procedures you can do once you have pericardial access. So the challenge for commercialization of some of these novel techniques is pacing and defibrillator technology right now is pretty mature and pretty safe. They're reliable devices. I pointed out some of the problems and challenges, but overall they're very reliable devices. So any novel tools have to be as safe as current pacemaker technology and current implant techniques, which are pretty good. There's always a challenge of a new method of implantation and transitioning some procedures from the surgeon to the electrophysiologist, which is happening for more and more procedures, from device closures of congenital heart disease to left atrial appendage, occlusion, those types of things. The long-term safety and efficacy of these novel techniques is unknown, and the first in human clinical trials usually are by compassionate use mechanisms. It's not going to be randomized, double-blinded comparison studies, because this is a small group of patients. You're never going to be able to do the types of clinical trials that you do in adults with atrial fibrillation, where there's millions of patients that you can randomize and double-blind. And so it's hard to convince companies that it's a good business proposition, and shareholders and the fiduciary responsibility that companies have to shareholders. You have to balance against the unmet need for clinical patients, and particularly kids. And so you have to argue that there's a bigger market. And so the application with adult markets is that pericardial access may be useful for a large group of adult patients who require pacing and resynchronization leads, particularly left ventricular leads, leadless pacemakers, which I know Carlo may be talking about in adults, ablation, epicardial ablation, drug and gene delivery therapies. But think about it, there's 30,000 to 50,000 adults who don't respond to resynchronization therapy transvenously annually that could benefit from a left ventricular epicardial lead placement. And if it can be done percutaneously, it may be done by the electrophysiologist and gain more traction. So the next generation defibrillator is kind of like the Bionic Man. One of my favorite shows in the 1970s, the $6 million Bionic Man. He said that he had to be faster, smarter. So these have to be smaller, flatter, smarter, and longer lasting. And so it's not inconceivable to be making a defibrillator that can fit through a needle. Electrophysiologists have to be creative. 50 years ago, this is how you were watching TV, and now some of you are probably watching now on your phones, right? So look how small things have gotten in 50 years, right? So this defibrillator from 1990, not that long ago, was a big device. And so it's very conceivable that we can make defibrillators that can go through a needle. I want to acknowledge all the people I've worked with that have made this possible, my lab in particular, the engineers and fellows in my lab, and the support I've received from these companies and other supporters. So in the end, defibrillators are life-saving devices, and even though I've focused a little bit on some of the challenges and problems, they're reliable and life-saving. So thank you very much. Doing questions now or after Carlos?
We'll do questions now.
Okay.
So do we have any questions from the audience? Great presentation, great talk. Yep. Go ahead.
No, congratulations, it's a wonderful presentation. I have just one curiosity. Do you know if ever was used a Tyrex antibiotics bag to avoid the high rate of infection in children?
We use the antibiotic sleeve. It's used in pediatrics. I don't think it's been used consistently. It was not used in our animal studies. And I don't know in the publication from France whether they used it or not. My personal practice is to use it for long duration redo procedures. I typically don't do it at the first implant or in a quick generator change, but if it's an epicardial defibrillator, I do use it, and if it's a long procedure, I use it. The only downside of it is the cost, right? There's no other downside to using it other than the cost. shouldn't charge so much for a small envelope. Yes.
Great talk, thank you. A question about how much defibrillation energy would be appropriate for something that might be changing as the child grows.
Yeah, no, that's a good point. I think, if we're talking about tiny patients, children under 5, say, my goal would be to get them to be 10. So I would think the initial, an infant or toddler defibrillator, probably 30 joules, would be more than sufficient with a high safety margin. And then they would need a standard defibrillator when they get to be 10 years old or pre-pubertal, they're going to go to a standard. But that would be a success. If we can get somebody to that age, if we can get them to 8 or 10 years old where they can get a standard transvenous defibrillator or substernal or subcutaneous defibrillator, then that's the goal of having an ICD for the smaller children.
And the size, if current defibrillators are like 33 cc's right now, how small do you need it to be?
I don't know, really, in that 1 kilogram baby, it's, you're not going to get anything bigger than the smallest, this very small pacemaker sized device. We've put in defibrillators in infants, but it takes up a lot of room. It takes up probably half of the abdomen, maybe more. We've had trouble with them sitting up because it rubs against the lower ribs. And so I don't have an exact size because it really depends on the age. And a 5-year-old, you can stuff in a small defibrillator. In a 1 or 2-year-old, it's got to be maybe a third of the size of the smallest defibrillator on the market now.
It's a fantastic talk, and thank you for being a pioneer in this area. These cases are fascinating and absolutely challenging. I'm curious your current approach to physiologic pacing. Some of the early evidence that RV pacing can lead to myofibrillar disarray. What's your thinking on that in these young patients and as they grow and you have to do lead change-outs?
Yeah, so I think it's a really good question. I'm still a novice and learning about left bundle pacing. I think we've learned from adult electrophysiologists that is probably better and better than his bundle pacing in terms of the technical challenge of doing it and the thresholds. And so I've been doing left bundle pacing, but less than a year. So I'm still on my steep part of the learning curve, but it's easier than trying to do his bundle pacing. And in children, it's definitely better than putting a lead in the coronary sinus, which is harder to do in a small coronary sinus. So we typically don't do what I would call pro-synchronization, meaning synchronized pacing in someone who has normal function. So someone that has heart block and normal heart function, we wouldn't put an LV lead in transvenously. But now, I'd say over the past 6 months maybe, I've been doing left bundle pacing instead of RV pacing. Whether that's better in the long run, we'll see. I think people are pretty enthusiastic about it, as you know, probably more so than his bundle pacing, probably because it's easier and the thresholds are better.
So back to pulling the thread of the pediatric ICD, which is so fascinating. So if we reduce the threshold energy, then we can, that has a direct bearing on the size of the capacitor.
Yeah.
Then the battery would relate to the energy as well as the number of shocks. So just off the cuff, about how many shocks maximum in a day would one design a battery for, as well as how many shocks over the service life of the device?
Yeah. Ideally none, right? So ideally the cardiologist is figuring out other ways, medications and ablation and other things to avoid shocks. So in terms of shocks per day, it would certainly be less than 1 per day. But you're talking about shocks per episode.
In the worst day.
Yeah.
Right? As engineers, we have to design for those boundaries.
Yeah, I still would probably have it deliver 6 shocks, like the current systems do, 5 or 6 shocks. And I've had patients that I've seen that have been rescued on the 6th shock, which is really scary. Rare, but I've seen one that the 6th shock was successful. And so those are pretty scary. But I would think, I don't know what the answer is. I'd say that I would want at least 4 shocks in a cycle. And number of joules, I'd say, is 30 joules, and number of shocks in a lifetime, a couple of hundred. I don't know what the current ones are. It's more than that. 100? Yeah. I mean, 100 shocks would be, hopefully you wouldn't get there. You know, there's probably more likely to have that many inappropriate shocks than appropriate shocks. Because if you start having appropriate shocks, the physician's going to do something, again, whether that's ablation or medications or programming changes to reduce the number of shocks.
I think we'll have to thank Dr. Berul again for the great presentation and discussion. If there's time at the end, we'll get them both up for our panel discussion. So, Dr. Diamandis.
Thank you so much, Paul, to invite me here. This is actually my first time. And I accept with full enthusiasm to participate in this Congress. And after I accepted, I was thinking, what am I going to say to the engineer? And the point is that, okay, I tried to figure out, and maybe I will use this presentation to complain to the engineer what I don't like in the daily life of a medical device. Or maybe, let's say, to be more constructive, I will try to figure out and give my impression of medical device. Now, the typical, in our lab, we apply a specific guideline for a label. So these are the way that we approach the label in the lab. So that's what you're going to see later. I hope will not scare you too much. But after the presentation before me, I think you will not be scared anymore, because that's, of course, was everything you saw is off-label, and I'm happy to see that. For one reason, because for many diseases, for many problems, we are not yet done. And the main challenge between cardiologists and engineering is to find, of course, the balance between the patient solution and the technological feasibility. So everybody push on their direction, but of course we have to find the balance between that, because otherwise we don't get there. One of the main concerning for me, and I don't know yet why we have to deal with all this hardware in our cath lab, and that's strangle me every day, because I'm really killed every day by all this hardware and all this cable that try to kill my fellow, my nurses, my engineering. Everybody risk every day to be strangled to this cable hanging around from the patient to the console. But in the end of the day, one day maybe somebody will tell me or will find a solution to build machines that can be compatible between each other, or anyway to sell more software and less hardware. You have to know that I have a computer, and everybody of us has one computer for each software we buy for each company. So you can imagine how many computers we have in a cath lab. Because its medical device cannot be sold apart. So any medical device is to close in one chassis, in one computer, let's say in that way. We are still, remember when I was a student and it was interesting to build up my experience in electrophysiology, one senior told me, no, don't worry, the company are working on build the common programmer to control device. I didn't see yet. I'm already thinking about retirement. But anyway. Then they bring this wonderful machine. I think that was the first revolution in CRM. Honestly, this was the great revolution, of course, the leadless, and was the first revolution. And we want to make a revolution out of this. And so when they bring to us, they told us there was endovascular device, but we didn't believe it. So then we decided that we believe can even work epicardially. So we have this specific patient that unfortunately she's suffering from a rare disease that, that we discovered when we implanted the first pacemaker. So she has a necrotic degeneration of the skin relating on the inflammatory reaction induced by the presence of the device. So when we implanted the first device, it was a simple pacemaker, and she never healed by the incision.
And in the beginning, we think it was infection. Then we treat it, we take out the device, we extract everything, we implant the second device subcostal epicardially because we think, okay, let's say maybe we hide a little bit more, it could be helpful. And again, went on this process. Finally, we decided to send to the dermatologist, okay, and the dermatologist take a biopsy of this region and they discovered that this necrotic disease. So we didn't have any solution for her. In the beginning, we have only the first generation Micra, and she has a sinus node dysfunction. So the first generation Micra, you know, is, and then to protect her by syncope, we implant the first generation Micra, but it was not enough to relieve her from the symptoms because the chronotomy incompetence, so she was not able to exercise and everything because the heart rate doesn't go up because the sinus didn't work. And the first generation Micra is a VVI. When he put in air mode, she even feel worse because it was not synchronized atrial ventricle. So you have a revolutionary device, and she didn't feel good about that. Then she developed, because the disease, I mean, it was a complex case, of course, being always the worst case. And she developed a very resistant atrial fibrillation, and we went through all process. We decided with the patient, because she was strangled by the symptom of chronotomy incompetence. It's not rare that atrial fibrillation take over of a sinus node that gets sick. And then we decided to treat the atrial fibrillation epicardially to give us the opportunity to implant this, that I don't know if you saw it. It's a Micra, implant epicardially on the heart, on the atrial side. So finally, today she has two devices. She has one Micra epicardially on the atrial side, and one the previous Micra on the ventricle side. Of course, the ventricle one, now it's on sensing mode because she needs just atrial pacing. And now she's released, let's say, from her symptoms, and she has a correct working on the device. And you will be surprised, and I have a regular phone call by Medtronic to ask me how is going the device. The device has very nice threshold, it's very stable, there is no fibrotic reaction around the tool, and is functioning perfectly. Of course, accelerometer doesn't work a lot, because there is not a lot to accelerometer. So we put in a VVIR, but because it's in an atrium, it works like an SSIR. So it's an old way to work, but it's actually this was the device that she needs only, but in the beginning we didn't want to go so aggressive. But in the end the disease evolved, so we could have opportunity to go epicardially. Now, implantation of the device would be a challenging, and of course, coming from the children population, just to give you a background of my center, the guy that founded my center was Pedro Brugada, was the guy that described the Brugada syndrome, if you ever heard about that. It's a genetic syndrome that affects children and adults, and is a channelopathy, so it's an electrical disease with a normal heart. So we have to deal a lot with a young patient, and then we try all our possibility to implant a device in a comfort way for our patient. So the main problem that we have a sorry, I did something wrong, and I solved it. So the point is, this is a traditional implantation of DDI, now DDD. Of course, in this disease, specific in the channelopathy in a young patient, we discover with many studies that if you have a dual chamber device, if you can detect the atrium, you avoid a lot of inappropriate shock. Inappropriate shock can be relating of all sudden death, of course, because if they are not necessary, but I can tell you, a patient that experiences inappropriate shock has a psychological impact that cannot be described. So it's really something that you have to avoid in any way, because as a young patient that experiences inappropriate shock, it's something that can be can make a lot of impact on his psychological point of view, can be very painful on the long term. Now, we try all approach. We try an abdominal battery, because this is a part that is very painful for them, and it's really annoying when they do a lot of sport, they move and everything, and if you are implanting women, of course, this could be very annoying of a movement, small chest respecting men. So we try this, but then we want to remain endocardially, so you see this long lead. That's actually, there is only one company that does, probably because they're very fan of NBA or whatever. I don't know why they do this long lead, but thanks God they do it. So of course everybody knows it's Medtronic. The problem is that the longer is the lead, the most place you have where it can be damaged. And even if it's tunnelized here and it's very fixed, there are a lot of traction on the movement of the patient, on the growth of the patient, on the exercise. So we experience a lot of, not a lot of problem because it was inside a normal statistic, but of course when you have a long lead, you will have more option of rupture. And to extract this, it's a hell. Because of course, when you have all this part that is tunnelized inside the patient, and this is easy because it works like a normal lead, but it's a dual coil, and because a dual coil increases the risk of extraction, and the coil can break. And the first part, it's very painful for the patient afterward because you have to tunnelize back. So we decide, okay, this is a nice implantation if it works well, but when you have to take out. And today, more and more, anything you put in, you have to be able to take out. So that's new. I mean, this is an approach in electrophysiology. So when you choose to implant something, so it's also the reason why probably you see on your side that we don't use anymore dual coil if we can, because dual coil is very difficult to take out. And then we decide to, because our course, our working together is together with the surgeons, so we have every week a session of epicardial ablation and thoracoscopic ablation. So we often ask our surgeon to help us to find a solution. And then we went in the room together, and then we decide to do what we do in children, what was shown before, the implantation of the pericardium. But then we decide to save one lead. So as you see here, so we decide to put a dual chamber device, but we don't put the second epicardial lead. For one reason, because if you screw the tip of your shock lead on the posterior wall on the ligament, pointing at the atrium, you are able to detect the region. Sometimes you can be more on the right side, more on the left side, but you detect the atrial region, so you can able to pace and sense your atrium. Most of the time it's on the left side, so you can pace sense your left atrium. And then you go down with your coil, that is one superior, one inferior, so you cross your heart, and then eventually, in this case, you can make 3 vector, you know better than me. And then you can do a DFT and check which is the best vector to defibrillate the patient. But the most important, if you don't need the atrial epicardial lead, the procedure is less invasive, because you don't need to go all over back, because you just put your lead in the pericardium, you move up with the scope, you find your region, you check your pace sensing. In most of the young patients, you do because you want to sense the atrium to avoid inappropriate shock, so this implantation could be very helpful. And the advantage to be in pericardium, we saw that it's very easy to extract. So when you have epicardial intrapericardial lead, let's call it like that, it's very easy to extract with respect of the subcutaneous. And this we designed, let's say, this approach before the subcutaneous came. So that's not an alternative we decided, that was before because we didn't have other opportunity. And then you have your epicardial pace sensing on the left side. It's very important that you are very concentrated when you connect the lead, that you put correctly, because you have to put your atrial lead in the right ventricle and your right ventricle in, no, sorry, I invert, you see. So the right ventricle pace sensing connection of the lead should be a connect on the right ventricle. Sorry, your right ventricle should be connected on the atrium, and your ventricle should be connected on the epicardial lead. So you remain with the 2 shock in the right position, and you have your atrium, your ventricle pace sensing that work as an atrium. So you have to correct connecting, and that was one solution. Now, what I say, everybody say, okay, but this is very painful. You have to because I have my fellow, when they arrive, they say, but you go thoracoscopic, or whatever. So it's very painful, whatever you want. But the problem is the daily comfort of the patient. And I always make an example. So to my fellow, if you are dumped by your girlfriend, your boyfriend, or your partner, you prefer a short pain immediately. You don't hear or feel your partner anymore, or you want just a text message dump you, and every day you feel it, that he call you, he text you, or whatever. So that's the point. If you place the device quite easy on the endovascular, and these young people, they do sport, bike, and everything, every day they are faced with the device. And psychologically, it's not underestimated. So they already have the shock of the diagnosis, they have the shock to receive a device, they don't feel any more healthy, even if these diseases are related on healthy heart, hemodynamically, because it's electrical disease. So they feel everything normal, but from one day to another, they are sick. Nothing happened, or they are, okay, the one they are reanimated, maybe they feel more the disease, but some of them, they are stratified by the risk, and so they are high risk, but for one day to another. If you can provide something that is comfort, I don't think they can forget the device, but they can accept better. And you can imagine for a young lady going on the beach, in Italy, you can imagine. I come from Italy. And you have a big scar with a big device over there, and maybe you want to be invited on the party or whatever, and then everybody asks you, what is that, so then it's not fun. For a scar here, you can always say that a shark bites you when you're snowing, when you're swimming, but for a scar here with a big device, point out, it's difficult to hide. And that is in a daily life. So you have to consider sometimes we implant patients with 18, 16, 17 years, they go to school, they go to gym, they go exercise. So it's something that you have to pay in consideration. I know that you are concentrated on what is the energy, how much you have to shock, the dimension of the device, what will be the cost, the production line and everything. But the comfort of the patient is a priority because it's a part of the treatment. So the way that the patient accepts the disease, accepts the treatment especially, could be drugs, could be device, could be anything, is a part of the treatment. So the most comfort and the most accepted by the patient that the treatment is, the most efficacy there is. An example, every time you have a trial, there is a placebo group controlling with a treatment group. If you look, all curve, in the beginning, the placebo go better. So there is always a psychological effect every time you give a treatment to somebody that he adds on your therapy. If your therapy will not be accepted by the patient, you lose this advantage. That is something that, because we don't want to give the best advantage for our patient, we decide, okay, let's take a pain, and let's take the boyfriend or the girlfriend. We tell that he's dumped, and we even send to live to US. We are living in Europe. Eh? What do you mean? That we decide to implant the device in that way, but we know that we are in front of what is the target of this disease. So we know when you implant this device, the port of the surgeons, they are looking straight forward to the right outflow. And that we decide to combine the two procedures because we know that we don't want to have a shock. We don't want to have inappropriate shock, but that's, we always blame the engineering. That's no problem. But for the real shock, we blame ourselves because we cannot treat the disease. So for inappropriate shock, we always say it's the algorithm didn't write well, so you know the company, whatever. But the point is that when you give an ICD, it's like when you buy your car. You buy your car, there is an airbag, but you don't want to use it. That's the same principle. So you don't buy the car, and they say, let's see how it works with the airbag. Don't do that. The same story, you implant an ICD, you don't want that it works. The best treatment is to implant an ICD and never shock. That is the best treatment you can give to your patient. So that's the reason that an ablation now, today, we do in the high-risk patient, we implant the device, and because the door is there, together with the surgeons, then I put this, you don't look a big difference between surgeon and EP. That's the reason I put a name on top. So electrophysiology is the cardiosurgeons. But as you see, we work simultaneously on the patient, and we can provide an ablation before implant the device. There are two advantages for this. We can use a different instrument from the surgeon, so we can ablate more because the area is quite big in one shot, so we don't need to do 3.5 millimeter each time, but we do in one shot over the RVOT, and immediately after we can implant our device internally, again with atrium and ventricle. And the other point is that after you implant this device, to perform this ablation is very difficult. So there is an advantage on preventive ablating to avoid shock, and also maybe in 20 years of follow-up we will discover that ablation will be more helpful, and maybe the device could be avoided, or I don't know, but we need data from the next 25 years. But perform this ablation when you have a device in front of the RVOT will be difficult. So the point is that we have to gain the best out of this situation. So we combine the two procedures together. So that's evolving on the next step. Of course, the company, they don't provide us a nice mapping system. So because the mapping system has a limit of the impedance and is not able to work correctly when there is a single low ventilation. So the impedance of the lung is gone. That's the best you can get out of your mapping. So this is an epicardial mapping. We map only that region, because if you move far or you can't portray all volume, the mapping system doesn't give you the volume because there is a flat, because there is a limitation. And many of the company I contact, they don't want to help us to improve in that way because they don't see a market on it again. And then we are struggling on that. Thanks God we use other systems. So as you see, we combine an external non-contact mapping, so you see the patient is in this setting. with ready for a thoracoscopic approach. We just lose this electrode on the lateral to put the port of the patient, the surgeons, but doesn't matter. The RVOT is mapped from that region, so we can have all this map, and then we can get the map combined with the epicardial map, and we have the region that we have to ablate. We do this also for other diseases. As you see here, we use right ventricular dysplasia, we do the same, so we localize the region that should be ablated thanks to the cardio insight, and then we combine with a local epicardial map, and then we can provide ablation and implant the ICD. Now, just to give you another backup, it's probably not a surprise for this university because I know they run a program like that for more than 30 years, but in Europe it's quite innovative. So we are running a program for electrophysiologists and cardiac surgeons as a university course. And for a few years we start also to combine biomedical engineering running together with our cardiology and cardiac surgeons. So we use all our facilities. We have a hands-on region. We have a smaller animal lab than yours. I mean, it's not so beautiful. Like, that's the reason we collaborate with Paul, because we like his experience and knowledge and facility. And in this way, in this world, especially in the animal lab, it's stupid to build everything double. So I think we have to collaborate more. And then we have satellite group, and then there is a teaching hospital with all these people work inside and collaborate with other university. Why I say that? Because then with the engineering program, and together to explain the procedure we did, we try to build a new tool because the engineering on the industry, they don't make for us, so we decide to print out the tool for us. I'm joking. But the point is that we developed this. This is a 3D printing guide. It's a teaching purpose. So we start now to train our cardiac surgeons, because you have to know, and please do not tell around, a bypass, it's very relating on the experience of the cardiac surgeons. The place that the cardiac surgeon put anastomosis is based on his experience. There are no technical, quantitative way to decide where to put anastomosis, because when you do the CT scan, the coronarography, they see the lesion. When they go on the heart, they don't see the coronary artery because they are covered by fat pad. So based on their experience, based on where the anastomosis needs to be implanted, based on they put the anastomosis, the bypass works or not. So training people to do the bypass, it looks like a simple procedure. It requires time, it requires to assist many procedures to learn this experience. We try to make something quite objective, so this mask, it will show to the surgeons above the fat pad where the lesions are, so these are, and where should be the best place to put anastomosis. Now we are using this tool on the operation theater to train our resident cardiac surgeons to see if the training will be, the learning curve will be faster and will be more consistent. So we are actually doing this. This is one way that we can use tools and medical device in a teaching way, and also in a practical, to make a learning curve and a teaching a little bit more measurable and quantitative, and not only by experience. So this is another tool that we develop. These are all process of this tool. So we create this mask to give to the surgeons, because the limitation of a mapping. So we do create, there was the first paper that tests the response of cryoablation on the surgical tool to decide which were the best material that we should use to develop this mask to do not damage the patient, because we want to see also that there are not residual after the ablation. So that was with the cryo. Then we did with radiofrequency also. And to understand which one is the best material, to create a potential mask to use to guide the surgeon to perform an ablation. Because of course there is also timing of ablation that can be combined with timing of surgery. So during the surgery, the surgeon can also ablate, but the main issue is that some surgery is with no beating heart. So the surgeon doesn't have any signal to map. So the idea is to acquire the signal before, create a mask out of our electroanatomical mapping. There should be, there you are. Create a mask. This is one of procedures that can be used to create out of our mapping the file of the mask. This is all engineer stuff, you know better than me. My engineer wrote this paper. But the idea is to use a process that they can provide our mask. And in the end of the story, to create, so the two papers decide which one the best material to do that. In the end of the day, to provide a mask with the landmark The reason that it is so long is because you need the apex and the aorta roots to orient the mask. Because when the surgeon is operating, you have to orient the mask. The moment you put the mask will localize the area of the scar, and you can ablate it even with no beating heart, because you don't need to localize anymore the signal, because the signal will be analyzed in advance during an electro-anatomical mapping before the operation. So this tool can help, and it can help to have more efficient ablation, because the surgeon has a heart in his hand. So there is no best way to perform an ablation with the heart in front of you. And by the way, there is no best way to don't have a complication, because you cannot be tamponade when you have heart in your hand with open pericardium and no beating. So this actually is the tool. For this, we are ready to start on the human experience. So we are almost ready to run with the first feasibility and safety trial, and after we will try to see if it's randomized and ablation during surgery preventing of scar in ischemic cardiomyopathy could be helpful to the follow-up of the patient to receive less shock, less episode, and create a more efficient lesion. And that's, of course, because our big experience, we are applying also for Brugada syndrome. So we developed this mask out of the CardioInsight map. So with the CardioInsight, we perform Ashwelin test, so we see the area of delay in the right ventricle outflow. Then we develop this mask with a landmark on a coronary artery. That's in this way. The mask is so small for a reason, because this is performed during thoracoscopic. So the mask needs to go through one of the trocar of the port of the thoracoscopic. The surgeons can fix this mask on the heart, and then it can ablate over to avoid the limitation of the mask with single long ventilation, everything. So this is another tool that we developed together. That's just I want to show you how it could be efficient to make electrophysiology and engineering working together on the same problem to find a very impressive solution. That's the reason that I go to my conclusion. Cardioelectrophysiology is the very high-tech, and that's the reason there are the Congress, and I think many of the solutions can only be found if we work together as electrophysiology and bioengineering, medical engineer, and bioengineer and engineer, whatever is the specialty engineering that you choose. And that is very important, because we are missing many opportunities. Also, it's very important because my fellows, they start to understand more and more how to switch on a computer, how a mapping system work. Actually, they are more behind the story, because you know, the risk is that the doctor today, they believe too much in the medical device, and if every time they do ablation and they do not even think where they should do ablate before do the map, I always told them, you don't go home using Google Map, because you will never reach home if you use Google Map. So first you have to know where you have to go, and maybe you activate Google Map. So the point is that the map can be helpful, but still the knowledge, the clinical knowledge should be important. And then I think a clinical knowledge, it should be, and that's what we do, and you do also here for a long time, you should share with your engineering. That's the reason that if you want the best medical device, you should combine the clinical knowledge, give through the engineering, and the engineering and technical knowledge give through to the doctor. And then you end with a beautiful solution like we saw in the previous presentation. And then I invite all of you in Brussels, where we have the best beer in the world, and the chocolate also, if you don't drink beer, that is also possible. And that is a beautiful city, and I will invite you all lab to want to see our center. Thank you very much.
Great talk. You can see how they both were very complimentary. I can ask a question first, because I got the mic. Yeah, stay there. We'll ask you questions first, and I think we're doing well on time, so we can have Dr. Berul come up in a minute. But you know, the masks are great. You put them on, it's practical. What do you think, though, of using augmented reality in the future? Where I have, you know, vision, I can see it, but the map is digitally there. It's overlaid on the heart. We have enough technology where even if I move, my mask should still be there as I look down on the heart.
I think that's a great point, and I think that the mapping system will move on that way. I think the mapping system will move that way. The reason we use the mask is also do not damage the area around. So why we want to have it's a kind of filter, because in some some of the problem that when you ablate too much, you create other region of re-entry and possible arrhythmias. So the mask is a guide, but it's also protection. That's all two paper in the beginning was to find a solution, do not eat or damage the tissue around. But for sure, you're completely right, because you can also have a device that delivers energy only where the virtual reality is showing. I mean, I don't see as a limitation. The problem is that, as usual, we have to do all steps to open the mind of the market to go over there. We can never get with artificial intelligence immediately, I guess, but for sure that's the direction, I guess.
Other questions from the audience? Dr. Lasky.
Thank you, Carlo, for a fantastic talk and for being an amazing clinician and friend. You have a very unique program because the PhD students, there are many PhD programs in biomedical engineering. One of the strongest is here at the University of Minnesota. But the PhD students are working in your lab every day alongside the physicians who are also getting their PhDs.
Yep.
And my question is, as we're training engineers to move towards a PhD program, what do we do well and where can we improve so that they're better functioning within your lab?
Yeah, that's a good point. So actually, you know, young generation today, they're very pragmatic, so you have to give a deal. And the beautiful deal that we create is that we ask them to come to do research, and in exchange, we invite them in the lab to learn the job of the mapping, CRM support, and all this work that today the company support on the cath lab. So for us, it's a big advantage because we have people that they are completely free of any marketing idea to support a case, to look clinically. On the other hand, we teach them a job that could be helpful on the future, because most of them, unfortunately, some of them even the company pick up on my program before they finish even. And because now I have two, they already work on the company, they are finished the PhD now. So I think it was a good idea to put both on table. So I say, we can teach you a job that we think should be training from the university and not from the company, because we believe that these engineers should be built on the clinical point of view before on the technological point of view. And that's what we do on a daily basis. So what we do, they work with our cardiology, they learn the clinical part, they work with the mapping, they learn from a company how to work in mapping, and they still work on the feedback daily with us. So the capacity of the lab improved because I have many people that support the case. But the EP cases is not anymore done by the cardiologist himself. It's done by the binomium between the people behind the screen as a biomedical engineer and the cardiologist. And if you do research, if you have somebody that has timing with a research mind because he's running a PhD with us, during each case you can find the idea for research. I don't want to say, but the company person is more busy to see what is the schedule for the next day, and it's completely normal. So if you want to build up a research program, you have to involve them in a daily job. That's the point. And in return, you give them a job for the future, I mean.
Yeah, and to Carlo's point, one of his students, we were hoping to hire her when she graduated with a PhD, but somebody hired her before she did. So.
Yes, yeah. That's the point. No, I mean, we find out that we find the gap of the market for sure in Europe, where these students didn't have. And consider this postgraduate is joined with the engineering faculty. So in my faculty, I have so that they have two engineering professors. They work on the postgraduate, so they receive PhD tutorial also. Sorry, the engineering tutorial.
So both of you talked about epicardial access and procedures, and a lot of times we hear like only 5 people in the world know how to do that, right? The SOSA procedure.
We want to keep your attention, that's the point.
So do you see epicardial procedures, like the growth of that starting to explode? Or do you get these specialized cases like Brugada cases because you're a referral center, and we're seeing two of the experts here in the room?
Thank you for your question, because there are many. So first of all, I will answer, or if you want to start, they are not so rare like we think. So many diseases like Brugada syndrome, also these. So for example, this disease, there are more diagnoses every year. In my way, I see more and more, because now we are working, we develop a new technique for inappropriate sinus tachy and POTS. and we are running now FDA trial, and I'm going for a trial to train center in US. And I have a feeling that the cardiac surgeons, they are looking for procedure. Because thanks to the fact that the primary PCI, percutaneous valve and everything, they drop dramatically in a positive way for patient, the procedure of cardiac surgery, I believe that there is a market coming up for cardiac surgery in that direction. In other hand, I'm always afraid when the company talk to me about a device fix everything, because in medicine, there is nothing fix everything. So I think diagnosis of complex disease is coming more and more on top. And the cardiac surgeons, they are searching more and more new frontiers. And that's, I think, epicardia will not be a limitation anymore in the future.
Yeah, well, I agree. I actually took Carlos' card so that I can learn how to do some of the hybrid sinus node ablation that he's published. But I think that the ultimate goal will be to take it out of the surgeon's hands, as we've done with other procedures, and have the electrophysiologists learn these techniques. I agree that collaboration with engineering is crucial, but as we make it more minimally invasive, and cardiologists, interventional cardiologists and electrophysiologists feel more comfortable in the epicardial space, that's going to be one less thing the surgeons do rather than one more thing the surgeons do.
No, but if you think, if you really want to look the history, atrial fibrillation ablation started with the surgeons. So the very brave person was Dr. Cox, without any electrical idea, and he started to do this atrial fibrillation ablation, and still stuff that he decided at the time we apply with the catheter. So I don't see the disconnection between them.
So I have another question, and for both of you, and that is, you know, the Micra and these kind of technologies also allow for telemedicine, but they actually have the triaxial accelerometer in there. So is there an optimal place to put that Micra that you would see that would enhance its use? And can that also be used to monitor the patient via telemedicine in a better way?
That's a really good question. I love that question. And the answer is I don't know. But I think that clearly inside the heart is not the right place for an accelerometer, right? But they're using it for a variety of reasons, right? They're using it to mimic getting P-wave sensing. As most of you in the room know, that's way more engineering than clinical. And we're trying to learn what's the best way to optimize the programming, and we're happy if some of the AV synchrony is there, right? If you get a certain percent of AV synchrony, you're happy with it. Whereas with a standard transvenous or epicardial system, you have the expectation for a dual chamber device that you'll have 100% AV synchrony if the device is working properly. So I think eventually we'll get there as the engineers figure that out. And as far as where to place it, no, I don't know, because right now transvenously there's only one place to place it. Epicardially you have more luxury of finding ideal spots, as you've shown in your case, and we've done in piglets but not humans.
No, I agree. I mean, the problem, I mean, when I look telemedicine, it came out as a tool for engineering, because it was the way that the company and anyway the engineer want to have the best way to follow up the technology that was home and to prevent any failure on time to help the patient. In my opinion, the reason that when it never take off clinically is because it was never integrated with the clinical information. So it took ages before we could have some information inside the device, or was combined with our medical file. So for example, if my nurses, they do the control, we do link with our system, because if you have an AFib in a patient that is detected by the device as sent over, and you know the patient is anticoagulated, is known and been ablated, the patient is very well known, so it's a kind of reaction. If you have atrial fibrillation, it's not anticoagulated, then you need another reaction. So the reason that is not yet integrated clinically, I think is not take off like should be. Because I believe that we can do a lot of remotely, but we have to again work clinically and technologically. It's a huge tool today to follow technologically the device, but clinically we are not yet there. For system like optimization, so patient I think should be, it's you know, it's like I always make example when you make clothes on site, I mean handmade. I come from Italy again, so that's... So the point that regularly you should go to check them and see if they still fit on you. So I think we will never stop to see patient. That's, I think, will never happen. But for sure you can combine an information that could be acquired physically and in phase on something that could be on monitoring.
Well, that's the Milan thing going on
Yeah.
there, right? Perfect.
Anyone else? Or I'll jump in with question 2. Here, I don't want to take all the questions.
Yeah, so I had a question regarding the pediatric population and...
Please come here. Let's sit here maybe.
Okay,
Right, so
that's better.
You're ready.
the question was basically, you'd kind of hinted at the implications associated with having leads in the transvenously. Could you go over like specifically like the developmental consequences of that and what that looks like?
Can you, what do you mean by developmental?
Well, so like, I mean, the entire chest cavity grows as the patient gets older, and I was wondering if having that fixed cable would influence like the vascular growth that would be different than a healthy patient.
That is slinky, yeah, absolutely. So when I, as a pediatric person, I think developmental. I think more psychological. That's why I asked to clarify the question. I wasn't thinking like an engineer. Yeah, you know, clearly that the challenge is that the leads get fixed into the vascular space, into the venous space, and if they were loose in there and could grow, then you could just put in extra slack and allow that slack to grow as they grow. And in concept, that works very well. But there's certain points where they get stuck. The fixation points under the clavicle, at the right atrium SVC junction, at the tricuspid valve, and then epicardially where it crosses into the thoracic space at the diaphragm. So we sort of know where the stricture points are, and trying to have the cable have enough slack in it between those stricture points. Whether there's some engineering fix or some chemical fix, hyaluronic acid or something, to keep it from sticking, whether it's in the pocket or along the track, would be the answer, because that's one of the unique differences between children and adults is that children grow. And so rather than having the lead in place and it's sticking, it's fine if you're not continuing to grow. But we do have the expectations that leads will eventually break. If you put in a lead in a child who's prepubertal, usually by the time they hit adulthood, they will have had lead failure, whether it's from the linear growth or the fact that they're more active than elderly adults is more of a debate, but it's probably some combination.
It's a great answer. Maybe we'll have a telescoping lead. Maybe someone can come up with that. Question back here.
Clearly, you both do a lot of pericardial access. I'm wondering, do you foresee there is a learning curve that you could get to that you don't need a camera to do that access?
That's good. So that's my 4 o'clock talk. So there are other tools and technologies besides direct visualization. There's some indirect ways of knowing whether you're in the pericardium or not, from the primitive way we use of injecting dye and fluoroscopy to seeing if you're in the pericardial space to some algorithms that detect the touch of the pressure algorithms that one company has that they market as a more safe way of entering the pericardial space without direct visualization. I think that people like Carlo are at the forefront of this, and most electrophysiologists right now are not comfortable entering the pericardial space, and even amongst the ones that do, they're doing it with contrast and fluoroscopy.
Yes, that's the whole point. So the technique is depend always how common is and how many people is used. For example, the main problem of implantation that there are many implantations not done by electrophysiologists. So there are some electrophysiology that is only dedicated of implantation, and I don't know if it's US is also like that. This is people, and the majority of the normal device, not in children, but normal devices are implanted by people that do only implantation. And you have to think in their way. So they just know the puncture of subclavian vein. If you ask a femoral puncher, they can have trouble sometimes because they're not daily used to do that. So if you ask a epicardial puncher or pericardial puncher, it's more common in EP, people do VT ablation, that they're not often the people that are involved in. So we are talking about this because we work in a complete lab with all approach and everything, and it's easy to jump from one side to another. But if you look the main market around, you have to teach a procedure to somebody that is not doing ever an pericardial ablation, if only in emergency. In emergency, it's easy because when you have a tamponade, you have a space to puncture. So that's a completely another approach. When you have to puncture without the liquid, then it's another way. And also cost benefit is different. But I don't think, I mean, when you design a device, you should be free of everything. So we are not super smart as a cardiologist, but we can learn new approach. Let's say that, the way that you make straightforward the procedure is the way that your device will take off. So the point is that if there is, like I saw from him, that there is this beautiful port that you can place there, it seems that he has a potential in an introduction. But of course, everything can have a learning curve. It's not limited. But this device will be easy to use by electrophysiology than by implantation people, I say.
One important thing to add to that about non-electrophysiology implanters, the vast majority of them don't program the devices, and they rely on you. They rely on the engineers of out-of-the-box settings is how they're programmed. And so it's important that your out-of-the-box program settings are going to work because most people just use those settings and don't customize it to the individual patient.
Some people look just the color you put on the lid to know you know how the story is? So when it's blue is the sky, when it's green or brown is the ground, so up and down.
Well, great. This was an awesome session. Thank you both again for all your knowledge and your insight and taking the time to be here.